Okay. All right, everybody. I think we're starting to let folks kind of filter into the meeting here. This is going to be our November ocular surgery grand rounds. Joined here with Dr. Peter Hovland, who's going to be our MC this evening. You know, we really enjoyed putting these on for everybody, so I'm glad you can join us. We're our standard profile will go for about an hour. At the end, so at 7 o'clock, we'll put up the information for the CME credit and the COPE credit. So we'll pass that information along so you can obtain your credit. As always, if you have questions, please use the text function and we'll try to get your questions answered as we go along. And we'll go ahead and turn it over to Dr. Hovland, who's going to set us off this evening.
Thanks, everyone. It's been a lot of fun putting these on, and Zach, you've been a great host of all of this, and we hope you guys have enjoyed it. We certainly have, and every three months we like to rotate topics, and today we're coming back around to retina again. And we're very fortunate to be joined this evening by Dr. Adam Martidis, and he was, just to give you a little introduction on him, he's of course a retina surgeon who is now with the group in Colorado Springs, Retina Consultants of Southern Colorado, some of whom I hope are joining us tonight. At any rate, Dr. Martidis trained at Duke University in undergraduate, and then he was distinguished as chief resident when he was in his residency at Indiana University, and obtained the prestigious Grayson Leadership Award, which is pretty rare and distinguished. Of course, then in a time-honored tradition, he went on to vitreoretinal fellowship. The smart, hard ophthalmologist residents are lucky enough to go on to retinal fellowship. And he trained in Boston at the New England Eye Center. Following this, he trained at the Wills Eye Hospital. I'm sorry, he took an academic position at Wills. And this is one of our big, famous training programs, especially in the field of retina. And so we're really glad to have Dr. Martidis here carry on our topics, which, as you know, are by our title of our lecture series, are focused on ophthalmic surgery. And so he's bringing us, some of the latest advances in our field, and has some very excellent video we're hoping to enjoy. And in our distinguished panel, we have Dr. Mimi Liu and Dr. Brian Jundeff from Colorado Retina, and joining us as a panelist, and providing perhaps some historical perspective as Dr. Ken Hovland pictured as well. So I've talked enough. Adam, you've got a lot of wonderful things to share with us, and we look forward to your talk.
All right, thanks, Peter. And I want to thank the panel, also thank the audience, everyone who's participating. I hope you can enjoy this. What we learned from literally day one of our training is that our field is, quote, visual, both literally and figuratively. So what I've tried to do is every single slide will have some kind of visual reference, whether it be a fundus photograph, OCT, video. So I hope you find this useful. I want the panel to chime in at any time to try to help me out and give their perspectives. So let's go forward here. So we'll start off very quickly, just briefly touching on the advances, because I want to focus more on the surgical diseases in which we'll actually show these advances in action. And I've split it into 4 sections, 4 major surgical diseases that we deal with: epiretinal membrane, macular hole, retinal detachment, both standard and complex, and diabetic retinopathy, in which we'll talk a little bit about vitreous hemorrhage and traction retinal detachment. So there's been tremendous advances. And again, I don't want to get too detailed on this slide, so I'll go through very quickly. We've introduced small gauge surgery over the past 20 years or so. We've gone from 20 gauge to 25 gauge, introducing a concept of minimally invasive vitrectomy surgery, or MIVS. When I started training, if I remember correctly, the big deal was having 1,000 cut rate. Now we're up to 10,000, which helps us with control during surgery, being able to do some of these more advanced maneuvers close to the retina. We have improved visualization. Remember the old halogen lighting? Now we're xenon. We're stealing from all the car companies that are trying to sell us these new headlights with the xenon. We're also able to see tissue better through staining with substances such as ICG, Brilliant Blue, Highlight the Vitreous with triamcinolone. I'll show you some of the new innovative instruments. And we've had vitreous substitutes using heavy liquids, oil, gases. But let's get on with the show. So I'm going to start a video that just shows how we start pretty much every vitrectomy surgery these days. Small incision. In the old days, we used to need about 1 millimeter incision. Now that's down to close to 0.5 millimeter with 25 gauge. And this allows us to not have to cut down the conjunctiva, not have to use cautery, not have to use stitches. So you see how quickly we can get in the eye. In this case, you can actually see some vitreous hemorrhage behind the lens that we're going to be operating on. But just like that, we're able to put our 3 ports in, one that's infusing fluid, one we're going to use to illuminate, and then third would be the working port to put our vitrectomy instrument or our laser. And then when we're done.
Quick question, Adam. Why do you angle them? What is the purpose of angling these rather than just going straight in like you're stabbing in?
Yeah, so interestingly, that's probably a bit controversial. I would ask the panel the same question. I do it to try to prevent leaks. I try to create a little trapdoor effect in the sclera such that the pressure of the eye closes that trapdoor, if you will, and leads to less postoperative leaks, postoperative hypotony, potential infection risk. Anyone else have a comment on that?
I agree. It's I just thought I'd bring it up because part of the beauty of these small incision surgery is that this is self-sealing. If Adam shows some pictures at the end of the case, you won't see him stitching the wounds up like we used to do with 20 gauge.
Right.
So it's analogous to the cataract surgery these days where it's sutureless. You make a beveled incision that self-seals, and that's we're trying to mimic the cataract surgeons here and have nice white eyes like this after surgery, which back in the old days, when I started practice and Ken was in his heyday, the eyes looked horrible after surgery. They were red and looked like they went 15 rounds with Mike Tyson. Now the eyes look great.
Yeah, I remember one of my co-residents at Indiana University, that was in the mid-90s, like, why would you want to go into retina surgery? All the eyes look like meatballs at the end of surgery. So yeah, we've come a long way. This is starting to compete with our colleagues in cataract surgery, I think. We'll keep moving on here. So let's talk about epiretinal membrane as our first subject. Again, I'll go quickly through and then we'll concentrate more on the videos and the panel discussion. I think you'll find that more interesting. But epiretinal membrane is a
Gabby, where are you?
avascular fibrovascular membrane on the
It's on that.
macular surface. It's heralded by a proliferation of glial cells, retinal pigment epithelium, and hyocytes. There are 2 types. There's the idiopathic, which is the most common. And the way I like to explain that to people, someone gets a posterior vitreous detachment and the gel separates. And most of us, it separates from the retina. In people with epiretinal membranes, it separates more like an onion, where the inner layer separates and the outer layer stays stuck to the retina and then allows for the proliferation of these cells and the contraction. So what we're doing during surgery is basically doing what nature should have done and getting rid of that outer layer. There's also a secondary form of epiretinal membrane, which can be caused by vascular occlusion, uveitis, trauma, surgery, or retinal tears. Here's a good example of an epiretinal membrane. This is from literally last week in my office. You can see the date of October 30th. Demographically, these epiretinal membranes are most common in those over 50 years old. That happens to be also the age where people have posterior vitreous detachments. There's an equal gender distribution. If any of your patients ask, what are the chances of me getting in the other eye? The answer is going to be 15%. Patients typically complain of distortion and metamorphopsia due to the irregularity or traction on the fovea and associated blurred vision. On clinical examination, here's a pretty aggressive or dense epiretinal membrane. You would look for macular striae. You can see these striae here caused by this epiretinal membrane. Other things you want to look for is inflammation to see if there's any underlying uveitis as a cause. Look for any hemorrhages, looking for any underlying vascular disease. And you want to do a careful peripheral examination to see if there are any retinal tears that are contributing. we'll usually get an OCT, and that's going to show us the degree of traction and where the traction is. Here you can actually see the nasal side of the fovea is a little more elevated than, let's say, the temporal side, because this thing is pulling up and over this way. We can also look at the degree of thickening and the foveal contour, in this case, the lack thereof of a foveal contour, because it's been obliterated by this membrane. We can also get fluorescein angiography. One thing that we see is all these wiggly lines, which is where the cellophane, so to speak, is contracting. And also, if you notice the straightening of these blood vessels, because the membrane is actually stretching the retina. So a lot of the times these people report a unique kind of double vision because their two foveas don't line up, excuse me. The other thing we'll look for on fluorescein angiography is leakage. This patient doesn't have particular leakage. And as we talked about before, underlying vascular disease. So let's start a case. I'm going to show you the green dye is indocyanin green. We use that to highlight the surface of the retina that we're peeling. And I'll show you how this is accomplished. So we put the dye in, let it stain the surface of the retina. It tends to stick to the internal limiting membrane. And then we have a good stain, and we'll put our forceps in. We'll find a nice edge. And of course, all our cases go this way, where we just pull and it comes off in one big sheet, right?
Sometimes.
Exactly. So one thing about presenting videos is you get to pick the cases that look really cool. So this one, you can see the membrane comes off really beautifully. One piece, there's that white sheet of tissue, and patient's fixed. Now I'm going to show you another case. Is this? Sorry. Another case, but this patient did not have a posterior vitreous detachment. This is a secondary form of epiretinal membrane. So I still use the ICG, but in the first dose, I actually use it to find the edge of the hyaloid to create a posterior vitreous detachment. So for those of you who heard of a Weiss ring, where the vitreous comes off the disc, there it is. And so we can create a posterior vitreous detachment, but then we're not done. Then we go one step further and stain underneath and do the same thing again to stain the internal limiting membrane to actually get the tissue off the retina. Of course, one of our reps was in with one of these lassos, the only time I've ever used it in my career, but I figured it'd be cool to show. It actually gets the membrane started, and then you can grab the edge with forceps. You see how nicely the ICG dye stains that membrane, and then we create an edge and then propagate it around the center fovea to relieve all the traction. The way I like to explain this to people is, why do we take, and maybe the panel can chime in on this, why do we take the internal limiting membrane? The example I would use, if we just take the epiretinal membrane, the stuff on the surface, it'd be like a waiter coming to the table and taking one of those little metal things and taking the breadcrumbs off the table, whereas this is actually folding the tablecloth and making sure everything. So we take the innermost layer of the retina, the internal limiting membrane, off. Any comments from the panel?
Yeah, I like to peel internal limiting membrane. That way I know I have the epiretinal membrane. If I'm getting the bottom layer, whatever's on top of it, I know has to come off. And it should reduce the recurrence rate. Epiretinal membranes can come back, but if there's no internal limiting membrane, they have nothing to grow on and adhere to.
Exactly.
And lastly, the dyes stain the internal limiting membrane a lot better than the epiretinal membrane. So technically, if you see green or blue, if you're using brilliant blue and you peel the colored membrane, you're getting internal limiting membrane.
Exactly.
Yeah.
I would just like to chime in. Don't try and do this at home, folks. That is, you made it look easy. Those were spectacular examples. We all wish, we've all had cases like that and we love them, but commonly the cases are take a little longer than what you just watched. And, you are peeling a substance off of the macula, off of the fovea, which are, extremely delicate tissues. That was beautiful work. Thanks.
So yes, thank you. So I wanted to show you a surgical result. These are all, as you see, very recent. This is about 3 weeks ago. This patient came in for a postoperative visit. This is their preoperative visit on September 23rd. Vision was 2100, really pretty dense epiretinal membrane, traction, obliteration of the fovea. And then post-operatively, what is this, about 3 weeks later, we're up to 2025. And for those who think this is some kind of video trick, you can see this is the same eye. So you can see where the retina was all bunched up here, and now it's all smoothing out. We still don't have our fovea back. We're trying to get it. And as I watch this person, I'm expecting over time to get a little better. They may even be able to get 20/20 once that happens. But go ahead, Mimi.
An amazing result, Adam, in 3 weeks. And there was a question from chat saying, does the duration of epiretinal membrane affect the visual outcome?
In general, yes, but I think it's a combination. Duration certainly is one factor, but it's what's happened over that duration. So when I first saw this patient, I saw this nastiness here. I honestly thought they wouldn't have as good a result because it looked like there's a lot of disruption there. As it turns out, the retinal tissue is fine. The things that we look for that portend a poorer prognosis, if you get these big cystoid spaces in the retina and there's been a lot of leakage and damage, or you kind of do the math where there's swelling and then you kind of picture that swelling goes away and you're left with this little microscopic amount of retina in the fovea, you can kind of predict that they're not going to have as good a result. Any other opinions on that?
Yeah.
I agree. It's there's a bell curve in terms of vision recovery, and it's important that the patient understands that. There's some home runs like what you have that have spectacular improvements, and others not as much. It really depends on retinal architecture and how much disruption. I'll throw out a question for you for the benefit of audience members. They have a patient sitting in their chair with a cataract and an epiretinal membrane. How do you advise?
Yeah, it's interesting. If I prefer to have them have the cataract surgery first for two reasons. One, if the cataract is a majority of their problem, they may not need the membrane peeled. Secondly, with the cataract in the way, if they do need surgery, I can do a better vitrectomy. I don't have to worry about creating a cataract. I have a better view during surgery through the intraocular lens implant than through the cataract. And then as a final thing, when I have a pseudophakic patient, I routinely take the posterior capsule because one of the benefits of surgery is they get rid of floaters. The thing is, if they have cataract surgery afterwards, they almost routinely get posterior capsular opacification. They need a YAG capsulotomy, which blows all that debris into the vitreous, and they end up with floaters again. So if it's feasible, I prefer to get the cataract out of the way. That said, in the more old school days, people would say the cataract surgery could cause more edema, worsening of the membrane, but if you time it properly, I don't find that to be much of an issue. Any other comments on that?
What about
totally right.
premium lenses in these patients? Any thoughts?
I'm the wrong person to ask about that because I'm kind of anti-premium lens, because a premium lens for a patient, in my opinion, tends to be a non-premium lens for a retina surgeon trying to change focus. Every time you tilt the eye a little bit, you're in and out of focus and you're getting all kinds of aberrations. And then the patients, those lenses are really designed for people with like 20/15 potential, in my opinion. When you have this kind of situation, the patients have a hard enough time reading through a flat lens or a plano lens as opposed to a multifocal. So does anyone else have any opinions on that?
Usually gently advise them against any premium lenses if there's any macular pathology. And also the one thing I always tell everybody who gets surgery for a pucker is like, you're never going to be perfect, right? I don't know if you guys tell them you're going to 2015.
Yeah, this is perfect. And you can see how imperfect it is. So that's a great point. So I look at this and say, oh my God, this is amazing. The patient may say, yeah, but it's still a little distorted and I'm still 20/25 when I used to be, 2015 or whatever the equivalent was. So yeah, everything has to be put in perspective. So I agree with that.
I agree. You're making them better. You're not making them perfect. And that's important that they understand that. If you have a healthy macula and cataract surgery goes perfectly, you could have literally perfect vision. But with a membrane, not so much. The other thing I tell patients is that their vision can improve for up to a year, sometimes even longer. For patients you follow 2-3 years, post-peel, and the vision just slowly creeps up and that anatomy kind of straightens itself out. I tell patients it's like hanging up a wrinkled shirt. It's the wrinkles don't go away immediately, but if it stays hanging long enough, eventually the wrinkles work their way out.
I think that's an
Well,
excellent.
guys, this is a fascinating conversation. Looks like we have our first audience poll here. Zach, I know you're on board. Can you tell us how we do this thing? I see the slide, and here we go. Everyone should be able to see a poll question. Take a stab at it. Let's see what the answer is.
I don't have the
Thanks,
Jeopardy.
Peter. I was asleep at the switch.
I know a glaucoma doctor watching a retina talk. That's great.
I'll just let it run for about 30 seconds and then we'll shut it down, Adam, so I don't hold
Yeah,
it
that
up too
sounds good.
long.
Do I get to vote?
Just a question, actually, Adam, perhaps for you. Do you find that patients with diabetic eye disease have different outcomes, or are there unique situations,
I think it can
considerations?
go both ways. If they have diabetic macular edema and there's a major tractional component, you release that traction, they do better. If they have significant ischemia or significant underlying vascular disease, I think they do worse. The other thing, I think I can give you a specific example of a patient I remember that is more representative of diabetics, was sent in for a routine peel, and unlike the video I showed where the ILM comes off in one sheet or comes off beautifully, it takes multiple attempts and fragments because the membranes are much more sticky because of the way the basement membrane sticks with the underlying vascular disease. So I think they're harder cases to do. And I think if you leave traction, they do worse. If you're dealing with two diseases, basically, an epiretinal membrane on top of underlying diabetic retinopathy. But in select cases, they do fantastic. So
How do you guys handle epiretinal membranes in patients with really good vision? You get a patient that comes in and they're 20/25 on the eye chart, but they're symptomatic. They have distortion that's bugging them in their work, driving, recreation, whatnot. When I was in training, 20/25 epiretinal membrane, you wouldn't go near. You get fired if you suggested operating on it. But now, not so much. How do you guys approach that?
Well, I can answer from my perspective. I let the patient kind of drive that ship. I never encourage people to have surgery. I let them encourage me to operate on them. If they're symptomatic, I will operate on a 20/25. I'll give you one quick story. When I was at Wills and someone came to me as a CEO of a big corporation, Mr. Big Shot, and he comes to me and says, I just wanted to meet the doctor that was going to peel my membrane. And that guy is you. And I looked at him, he's 20/20 -1. And I looked at him back and I said, well, you want surgery, but who's to say I'm going to do surgery on a 20/20 -1 eye? And he was very impatient with me. He said, well, don't waste my time. I'm a very important person. You were on my list of people to go to take care of this. If you don't take care of it, I'm just going to the next guy on the list. I need this taken care of. It's driving me crazy. I said, okay, that's all I need to hear. We took care of it, and he's one of the happiest patients around, because if he starts off 20/20 -1, assuming nothing goes wrong, and that's a big assumption, they tend to be very, very happy because they have great potential, as opposed to the 2200 eye. No matter what you do for them, you're very rarely going to get them excellent vision. So that's kind of my perspective. Anyone
I think
else?
there's two points I would say. One, these are not normalized to begin with. They're abnormal. Two, we always worry about the micro trauma of the procedure itself. There's tight adhesions to the glial layer, at least, and we worry about visual field deficits after these sort of procedures, and so they're not entirely risk-free, and you have to have very careful conversations with your patients beforehand. That's for sure.
Yeah, if they have 20/25 vision, I usually try to talk them out of it, but at least wait and revisit in a few months and see if they're still very symptomatic. And I've done a few at that level. One is actually a pilot with 20/20 vision, but distorted. But she ended up being very happy. But usually I kind of drag my feet and wait a few months and just make sure they rethink it and get another opinion or whatever. But I tend to not jump into it right away.
So we could finish up with epiretinal memory. The reason I put this slide, the answer was 30%. So congratulations to those who got it. Most people, I think, thought it was higher, and that makes perfect sense. That would be more logical. But the prognostic implication here, most of these can be observed. So who do we operate on? Well, obviously operate on the ones that are getting worse to stop them from continuing to get worse, or at baseline, someone who has significant symptoms. The rest you can say, there's a 70% chance you're going to stay like this. So if you're fine, leave it alone. Let's move on to macular hole real quick. What is a macular hole? Dehiscence or horizontal splitting of the fovea caused by vitreomacular traction. Typically occurs between the ages of 50 and 70, younger in myopic patients. There is a slight female preponderance. I'll give you a preview. Our audience poll is going to ask if someone has a macular hole in one eye, your patient's going to ask you, what are my chances in getting it in the other eye? And we'll do that in our poll question. Let's hold off on that. We'll get to that a little later. Thank you. And people complain of central visual loss. There's a big hole in the middle of their vision, and metamorphopsia. There we go. On clinical examination, we're looking for that central hole with a cuff of fluid around it. It's much easier to see on OCT, and OCT can show us that there's a full thickness defect. Those are the ones we're generally operating on. We can evaluate the size of the hole, the presence of traction. You can see these edges starting to lift up here, and the presence of fluid here, a tiny bit of subretinal fluid, mostly intraretinal edema. And then I don't find this that useful, but we can get an angiogram, which will just show that hole very clearly with central hyperfluorescence. So let's do a case. Here's where I'm using Kenalog or triamcinolone, Kenalog the trade name, to highlight the vitreous and help me create that vitreous detachment to release the traction on the retina. And so combination of suction and cutting to get the vitreous off of the retina, clean off that residual Kenalog, and then we'll go back to our trusty staining with ICG in this case. And then this will be a little repetitive, but you can see the hole right there. And then we'll peel the membrane, the internal limiting membrane around it. And while this is going, we can have our panel chime in.
I love those cases that look like that. That patient's going to do well.
Yeah.
You found a cleavage plane and teased the tissues apart. These are the ones that are least likely to have any iatrogenic trauma to the retina. And I think question is, as we're seeing here in your surgery, it's just stuck there a little bit to the rim of the hole, if I'm not mistaken.
That's right.
How do you guys manage that? I mean, if I don't want to get too detailed, but what do you think of that? Fairly common thing to see.
I just gently pull it off.
Yeah.
You don't want to yank on it and perhaps enlarge the hole, but the only time I leave it is if I'm doing a ILM flap or patch or something like that, which is a whole nother lecture, but otherwise I just gently remove it. And the little hemorrhages you see are fairly common. The internal limiting membrane is the top layer of the retina. It's not pathology per se, it's physiologic, and it's supposed to be there. And peeling it, you get little hemorrhages like that. So that's common, just for interest.
Oh, by the way, I just want to add, so Adam was everyone's favorite attending at Wills when I was there some years ago, and Adam was like everybody's favorite attending, just a brilliant surgeon. And he brought the Kenalog peel to Wills back in the day when it was just starting to use Kenalog, and published a lot on Kenalog use before the day of anti-VEGF and all this other fancy biologics. So anyway, just wanted to thank Adam for that.
Just
Well-
wanted to add a historical perspective. I'd been in practice by 20 years by the time Dr. Kelly reported vitrectomy for macular holes, and I was at a retina meeting with him, and we just couldn't believe it at the time. But because prior to that time, everybody went home with their bad vision, and but it's been a great addition.
Right.
The membrane stains are really helpful. It's analogous to the cataract surgeons when they have to do a capsulotomy on a mature cataract, and they put the trypan blue in the eye and they can see the capsule, and turns a difficult case into much more straightforward. And that's the same for us. And we're kind of spoiled with the green and the blue and the different dyes, so we can actually see what we're doing. And that's a huge step forward in this type of surgery, any type of peeling.
So let's look at a surgical result. And this will actually allude to what our panel was talking about when that is stuck to the edge of the hole. And here we can see it on the OCT. That's what caused the hole to begin with, is the vitreous traction on the edge of the macula causing this hole to develop. So then we operate on this patient, 20/60 vision with a hole, comes back, what is this, 3 weeks later. Oh, actually, I'm sorry. This is a preoperative picture, but what the surgery wasn't September 30th. The surgery was, I believe this is the 1 week post-op. So it was mid-October, and you can actually see the gas bubble still here. And then our hole is joined, but we have this little residual dehiscence, which we often see early. But if you see the patient just a week later, that's gone away. The fovea is back. I think I can convince you this is the exact same patient. You can follow the architecture of the blood vessels, so we're not cheating here. 20/25 vision, but here's something very interesting. And this is something that we were just learning when I was a fellow back in the late 90s, crazy. So this is Dr. Williams' patient, if anyone knows Dr. Williams, who just retired from our group. So I was able to get an OCT from about 2 years ago. And we can see if we backtrack, isn't it interesting? Person was 20/25, almost exactly 2 years ago to the day, actually. And is that, no, I'm sorry, it's a month's difference, but still close enough. But you can see exactly where the person started to develop a posterior vitreous detachment, but they had that adhesion to their fovea, but they were fine, 20/25 vision. And then fast forward almost 2 years, and you can see exactly how this has evolved. And this just wouldn't release. So we went in there and we released it surgically, put the bubble in, and we get them back to where they were 2 years ago, and we're in good shape. So that's how things are supposed to work. Now let's talk about what percentage of patients. So someone comes in with a hole in one eye and you want to advise them, oh my gosh, what's my risk of having this happen in the other eye? Let's poll the audience on this one. There we go. And we'll give our 30 seconds and let our panel discuss some more. All right.
Adam, does the size of the hole make a difference? The one you showed was kind of small, some get bigger. How big do they get?
Yeah,
How does that affect what you do?
It used to be much more of an issue, but we kind of use 400 microns as a guideline. If it's under 400, the closure rate's going to be in the mid to upper 90% range. As they get bigger, there's more to close, but it's also usually a sign of chronicity where the tissue is contracting and it's a little harder to get that gap to close. So, well, the audience nailed it pretty much. That's good. Any comments on that?
And do you do a ILM flap or, or any free flap or anything like that?
Well, that's an interesting thing, because I have to honestly say, with the success rates we have, and I'll ask the panel this, because I haven't had that much occasion. I'm not one of these people who say I have 100% success rate. Of course I don't. But I think the success rate is high enough to the point where if you do a wide enough peel, you're getting closure rates 95, 96%. And then if you take off, let's say the other, let's say 98 to 100, which you can use almost any technique. Someone comes in with this hole that's as big as the macula, it's just not closing. the indication is very limited. It's that 1 or 2% of cases maybe. So anyone have any comments in that regard?
I use it for the larger holes and more chronic ones. A chronic hole is something that's been there for 6 months or longer by history. And technically, a large hole is 400 microns and up.
Correct.
I don't know. I can't do a controlled experiment in the single eye, but I tend to, for those with poor prognosis, tend to do a flap. They close. I don't know that they wouldn't otherwise, but
Right.
maybe it just makes me feel better that I'm doing something a little bit extra.
Yeah, I think I err on the other side. I would do it for a failure more than a primary procedure. But again, the jury's out on that one. Come back.
And do still have, I have like still half of the patients come in and say, oh, do I have to face down for 6 weeks? My friend had to face down for 6 weeks.
What do you guys do for face down? Because I'm basically telling people do about 4 hours a day for the first 3 days. So I've kind of tried to minimize it.
I'm not doing any. I stopped
Yeah.
a few years ago, and I just tell them not to sleep flat on their back.
I think that's very
If
reasonable.
I get a good gas fill, then they don't have to be face down at all.
I agree.
They'll do reading position, though,
I don't
Brian.
even do that. If you have a good fill, you'll have.
Yeah,
It's
right.
not that the bubble is exerting pressure. It's that it's sealing it. So
Correct.
Excellent.
I use a 25% SF6 gas mixture, and I'm going to have at least 70-80% bubble on the first day, and that'll seal the hole.
Yeah, I would agree with that.
Great.
All right, let's move
Fascinating
on.
topic. Yeah, let's see this next one.
Proliferative diabetic retinopathy. So let's real quick through the demographics. After 20 years of diabetes, the prevalence, interestingly, 99% of type 1 diabetics will have some degree of retinopathy. Not like this, but some measurable degree, which is, I think, pretty surprising. Type 2s, 60%. What are the risk factors? We all know high sugar. Duration of diabetes, we just said 20 years, is kind of a magic number. Comorbid hypertension, carotid artery occlusive disease, and if it's asymmetric, you can end up with asymmetric retinopathy. Pregnancy tends to make diabetic retinopathy worse. So what causes this? The abnormal blood vessels and neovascularization grows into the vitreous, and as the vitreous separates or contracts, it pulls on these blood vessels and they bleed. The bleeding causes acute visual loss, floaters from those free-floating red blood cells, and then over time, those neovascular fronds start to shrink and contract, and you start getting traction retinal detachment, which is the second thing we're going to talk about in this section. So on clinical examination, it's really hard to do anything because you can't see the retina. You can maybe look for red blood cells in the anterior chamber. There's limited to no view of the fundus. So we tend to rely on ultrasonography. And on ultrasound, we're going to look for hyperreflectivity in the vitreous cavity, mobility of the hyaloid face, and try to rule out retinal detachment. And I'll kind of maybe get a little bit into that, but not too much. Generally, we can't do fluorescein angiography because the blood's blocking our view. But if we did, we'd look for neovascular sources, ischemia, etc. So here's a patient, just not too interesting a case, just wanted to show you kind of what a massive vitreous hemorrhage looks like. This thing has been there for quite some time. It's just real dense hemorrhage, but that's just there for purposes of example. And then I'll go to the next video to show a little more about what we can do here. So this patient, let's start that video rolling, has a vitreous hemorrhage. You can see deep down there's some neovascular tissue that's coming off the disc and starting to gliose or fibrose. You want to try to pull that off the disc. You see in this case it's kind of stuck on, but you want to release the hyaloid or the vitreous face from there, because if you leave it, it'll contract and it'll either cause traction retinal detachment or more bleeding. So I'll go down with forceps, change lenses to a higher magnification, and just peel out with forceps. A lot of times we'll pre-treat with an anti-VEGF to try to weaken those neovascular fronds and make it easier to separate. And here it is separated, and then we can chomp it up with the cutter and get rid of it. And then I raise the pressure temporarily, just like you hold pressure on a wound so that it doesn't bleed. While the pressure's up, I get some laser in, some PRP laser with the probe in the periphery. I tend to treat very peripheral in the OR. I could always add a laser more posteriorly, but try to preserve their visual field. That's somewhat controversial. Clean them up, and this patient will do very well. The fovea is good. The macula is healthy. These kind of patients can end up in the 20/20, 20/30, 20/40 range. So they tend to be very happy. Have any comments?
I agree on the peripheral laser for the reasons you stated. It's that retina is ischemic. It doesn't see anyway. And that's the perfect retina to ablate. And it gives them bigger field. And you can always, if you have to add later, it's a lot easier to treat more posteriorly. So I'm 100% on that.
Okay. And so let's go on to traction retinal detachment, which is all of our favorite cases, I'm sure. There's horrible diabetics that come in with contraction. So these blood vessels grew in, and then the body starts healing them and contracting them. The contraction pulls on blood vessels, causes more bleeding. And then this white fibrotic tissue starts to lift the retina. These patients present with more chronic or subacute visual loss. You don't develop this kind of scarring overnight, obviously. And so here's a patient I literally operated on, I think in September. This is the pre-picture. So on clinical examination, we're looking for this fibrovascular proliferation along the arcade vessels and the optic disc, the neovascularization of the disc and elsewhere that became gliotic and white. They contracted. I think I can convince you, even though it's not 3D, that there's fluid under here because of this pulling of this tissue. I like to get OCTs on this patient because you're not going to believe this patient's like 20/80, but they have a perfect fovea. But look at where the arcade is. So you can see here on the bottom and the top, the kind of walls are closing in on them and the disc. So you have this big traction at the disc, and then you come across the fovea, and the fovea looks pretty good, except for this band coming across. And then the retina is being lifted. So the OCT, we're going to look at the traction along the arcade vessel. We're looking at the traction at the disc, and we can see some subretinal fluid here, obviously. Not much macular edema, which is why this person amazingly sees 20/80. This is not this particular case. This is the only case that's not me. I borrowed this one. And so here we have a case where you have all this proliferation, like we said, disc and the vessels, and we go to peel it off the disc, and it just doesn't want to come very nicely. And you see how tight that is, and we don't want to tear the retina. So we want to pull on it, but we don't want to pull so much that we tear the retina off. It makes for a very quick surgery, just not a very effective surgery. So there's where we have a lighted pick, and we can actually lift up with one hand and then undermine with our little lighted pick that helps us to kind of tease the tissue without yanking on it to create that plane and allow us to more safely peel it without tearing the retina off. The retina is very attenuated, very weak, atrophic, poor vascular supply. I don't know how patients with so little blood flow in their eye can bleed so much, but unfortunately they do. But you can see with the proper technique and patience, you can get them pretty reasonable. Let's see. Here's a pre and post of that first patient I showed you. And let's go on to my more recent patient. This is a guy who came in, yep, so he was in September, and as I said, he was 20/80. I wish I had the post-operative photo. He just came in a couple weeks ago, but you can see that we released that traction from the disc, that elevation along that arcade vessel, because that was causing the retina to tent up is starting to settle down. We still have a little bit of subretinal fluid here. His vision went to 20/60, but that's because we really got rid of a lot of the obstruction down the middle. He always had a reasonable vision. It's just that wasn't going to be that way for long as this thing crept into his vision. This is less of an urgency than a standard retinal detachment where there's a hole where they progress very quickly. These tend to progress a little more slowly. I don't know if we want to get into.
Yeah, so I was going to ask, what's the time frame that you would operate on these, and referral wise, does it have to be seen on a Friday afternoon, kind of thing with the track?
Yeah, these are tough because it's hard to differentiate, obviously. So, but no, they don't. These aren't emergencies, of course. But at the same time, you talk to the patients and you use the history, because this particular gentleman would tell me, I've just been losing vision little by little over the past several months, and it's getting a little too close for comfort. I feel like the walls are closing in on me. And generally, if you tease out the history, you'll find that it's happening very slowly, whereas the retinal detachment with a tear is going to happen very, very acutely. Comments on that?
Where do you guys stand? Well, this is a really good topic. Where do you guys stand on prepping these patients for surgery? Do you attempt to do PRP as much to whatever extent you can do, if possible, before surgery, or do you try anti-VEGF therapy for a period of time before surgery, or what are your concerns doing those sorts of things and thoughts?
I like having a lot of laser. I think in bad eyes like this, you can never have too much PRP, and that's it really quiets the eye down. So if it's extramacular traction, you think surgery is in their future, I try to get some laser in. Anti-VEGF, you have to be careful because it can cause the new vessels to shrink and contract and accelerate the traction and all of that. So I might do an Avastin injection a few days before surgery just to reduce intraoperative bleeding, but I like to get some laser in. It makes the surgery easier. The vessels it's just less vascular, less bleeding. It just makes life a bit simpler.
So we'll go to our next question. I don't know, is most of our audience local? Let's see.
While we're doing the survey, I'll throw in one other comment about urgency of this surgery. Patient that has this type of retinopathy, more likely than not, has high blood pressure, may have heart disease, may have some kidney failure. This is not the type of patient, even if you wanted to, you could bring to the operating room in a day or two. You try to get them cleared medically, and sometimes that can take weeks or months, because they have an EKG changes and their internist wants them to see a cardiologist. And that's a challenge with these diabetics. It's not just because you make the decision to do surgery and try to schedule it, you could be looking a month or two out before you can even do it.
Very good.
So I trained down in Texas, Adam, and I would say it's probably one of the few states where you can actually diagnose a new diabetic based on proliferative retinopathy. That was not uncommon for a patient to show up with vitreous hemorrhage or PDR and have no idea they were a diabetic. So definitely nice to live in Colorado.
Yeah, isn't that interesting? So it is the lowest state, and then we have our neighbor, Utah, Idaho, Montana, Minnesota. It's actually a small club of lower prevalence versus our friends in West Virginia, and then the deep South here, all that good Cajun, and like you said, Texas, they're on the other side of the equation. California's kind of down the middle. All right, where are we? Last section, retinal detachment. So annual incidence of retinal detachment, about 1 in 10,000 for a lifetime prevalence of 1 in 300. Risk factors, high myopia. Interestingly, lattice degeneration is present in 20 to 30% of cases. That doesn't mean if you have the opposite, if you have lattice degeneration, you have a 20 to 30% chance of having retinal detachment, but it does increase your risk about 10 times compared to the general population. Trauma is a risk factor. Aphakia, which we're seeing a lot less of these days, obviously. So what causes these retinal detachments? Usually occurs at the time of posterior vitreous detachment, where the hyaloid separates and creates traction at the vitreous base. Macular hole, traction at the edge of the fovea. Retinal detachment, traction at the edge of the vitreous base, creating a tear. Fluid gets through the tear and starts separating the retina. We know the symptoms: flashes, floaters, visual field defect, and eventually central visual loss if you let it get to that point. So what are we looking for? They talk about horseshoe tears. I think this is a great example of why they call it a horseshoe tear. We're looking for that retinal tear surrounded by subretinal fluid. Other clues we can look for is the tobacco dust or Schaefer's sign, which is pigment in the anterior vitreous that's liberated through this tear. And we look for that in the vitreous. We could also look for vitreous hemorrhage. If you have a patient come in the office and they're not diabetic and they have a spontaneous vitreous hemorrhage, they have a 70% chance of having a tear in their retina. So that's someone you want to really evaluate carefully and likely refer for a good peripheral examination. Here's a case that, again, just came in, a couple of weeks ago, 2-3 weeks ago. I like to use the OCT because here, the preservation of the fovea tells me maybe this patient has good visual potential, even though they're coming in hand motions. They have a ton of subretinal fluid, intraretinal edema. We can obviously tell that they're macula off. And here you can see, I always like to use this scan to see the exact extent of the detachment. We reattach them, and here we are, about 2 months later, hand motions to 20/40, looking really good. But when you look at the OCT, you still have that watermark line where the retinal detachment was. And the implication of that is if someone has a splitting of their fovea, if that watermark line goes right through it, those are the most miserable patients I see, because even though their retina can look perfect, they have this visual effect. So this would be interesting to discuss with the panel, because I've talked to this with the associates in my group. And if we have the macula threatened, we want to operate on it very quickly. If the macula is split, we almost prefer it to go a little bit further, because we don't want to put that crease, if you will, right through the fovea, right where the patient can see it. Any comments in that regard? Or?
I would agree with that. And I'm impressed how well some macula off retinal detachments see. Traditional thinking is macula off detachments, they're not going to see well, macula on, they will. And so many times I've seen the opposite. I've seen macula on detachments end up a line or two worse. They get a little macular edema, epiretinal membrane, or who knows what. I've also seen macula off detachments, even a week, 2 weeks off, come back to 20/25. It's really remarkable. So I'm not quite as urgent about getting these done. I'm not going to operate in the middle of the night for one of these, because they do well, and it's, I think, more important to get it done right the first time than try to rush it to surgery.
So
Yep,
we're doing
I
a good
agree.
session. Go ahead,
Did you
Mika.
guys see, what do you think of that, some talk about purposely leaving some subretinal fluid in the macula to let that RPE pump it slowly over time to have a better visual outcome compared to just suck out all the fluid when you're draining?
Well, that's kind of the principle of a scleral buckle. If you drain, you may get most of the subretinal fluid out, or a lot of the attachments, the more peripheral ones, you do a buckle, you don't drain because there's not enough fluid to drain, and they do quite well.
Yeah, it just seems to support that, if a little bit of subretinal fluid or mac off a little bit, and it can do very well. Just if you do it right and let that fluid absorb and get that RPE rehabilitated and do 20/25.
I typically drain through the existing break, and invariably there'll be a little bit of fluid left over at the end of surgery, and put them face down in the recovery room for 15 minutes to just flatten the macula. And
That's what I've been doing. So you see in these cases, I've been using the heavy liquid, but I've actually switched my technique to do exactly that. So if I do leave a little fluid in the macula, it doesn't bother me because it's gone within a couple hours. So
yeah, exactly. As long as you can get the periphery flat and be able to laser your breaks, then I don't worry about leaving some fluid posteriorly.
I think the face down positioning is key. The metaphor we used to explain to our patients, it's like if you're laying a sheet on a bed, you lift it up and you want it to lay exactly where it is supposed to lay. And thankfully, due to the action of the optic nerve kind of keeping a button down, I think it'll lay down. But there's a little fluid, and if they're face down, I think that'll come about. Just a question, I don't know if, Dad, you want to comment? You worked with Dr. Scapins with the upside down table. Didn't Dr. Scapins observe that in a face down position, a giant retinal tear, patients will spontaneously reattach to a degree? Am I wrong?
Oh, that brings back bad memories of 8-hour cases. And not too much success, frankly. Uh, those are so complex and ended up poorly by and large. I don't recall the exact mechanism of a good or bad outcome.
Okay, and we're gonna look at our results. So this is a patient again, saw July 7th with, you can see a bullous detachment, but the macula is actually detached, and we'll see that in a second on the OCT. And here's the post-operative result. What is that, about 6 weeks later, approximately? Here's her OCT. So again, her fovea got cut off because she had so much subretinal fluid. You can see the extent of the detachment past some cystic spaces, intraretinal edema, subretinal fluid, and then July 7th. And here we are 3 months later. I don't know how she saw 2200 here, but she did. And then back to 2040, and we can still see that watermark line we were talking about, but very good result under the circumstances. And then the last topic we'll talk about is all our favorites on this side of the equation, and that's these complex detachments with proliferative vitreoretinopathy. PVR, or proliferative vitreoretinopathy, is a proliferation of glial and RPE cells on the retinal surface, resulting in traction, opening of old breaks, or creation of new breaks. It occurs in approximately 5% of retinal detachment cases, and is the #1 cause of redetachment. Risk factors making things worse include uveitis, vitreous hemorrhage, giant retinal tear, or chronicity of the retinal detachment. So what are we looking for? We're looking for these fixed folds, foreshortening at the equator from equatorial traction. We can do ultrasound. This is an extreme example from a long time ago, but we couldn't see this because this patient also had a dense cataract, but you can see that a long-standing retinal detachment with thickening of the retina. You can see fluid in the subretinal space where this plugs in to the nerve. And I think I can convince you without a live video that this is not very mobile. So let's quickly look at the worst case you'd ever want to see: a giant retinal tear in a bad diabetic that's been sitting around for a while. So we use the heavy liquid to stabilize. We peel membranes. We got to get under the retina. We have to sacrifice some retina periphery. That's called a retinectomy, where we actually cut out the retina where there's too much traction, but we sacrifice the peripheral retina for the sake of sparing the fovea and the macula. And then 360-degree laser. You can see there's the macula is intact. The periphery still looks a little beat up. And these cases, we generally put oil in at the end. And after a nasty case like that, the eye still looks quite good. And we fill the eye with oil. We vent the air out. We do an air fluid exchange and go from there. And then my last video is this old school video from 20 years ago at Wills. And I had to, what Mimi was talking about with our Kenalog peeling, I had to kind of pull this out of the archives. And you notice the video quality from 20 years ago is not quite the same, but we use this Kenalog on a more complicated retinal detachment to find the tissue plane where all this traction is coming from. And we use a diamond dusted scraper to engage the edge and propagate it out. Then we'll use our heavy liquid to stabilize and work our way forward. So there's the heavy liquid going in. You notice the older 20 gauge, how much wider this instrument is. It's half the size of the optic nerve head. And then we stabilize and propagate out. And wow, it's 7 o'clock and we're like right on time. What a deal. And is that coming to an end? I think you get the idea. I think that's pretty close. But that's from 20 years ago. Literally, I think it was 2000 or maybe 2001. And real quick, some results. This is a guy that came to me on August 25th, 27-year-old who just chronic retinal detachment, nasty hand motion vision, operated on him on the 27th. So this was his 1-day post-op. I had to cut out. I didn't want to cut here because we would be basically taking half of his retina. So I had to basically unfurl all of this and get it to lay down and try to give him as much of a macula back as he could. But it did require sacrificing the periphery and then lasering that. And there's oil holding this in place. And on day 1, he's starting to count fingers. He's starting to get some foveal function back. And leads us to our last 2 questions. What percentage of patients with lattice degeneration and retinal detachment in one eye will experience a retinal detachment in the fellow eye?
Just a comment for the panel, I don't know your experience, but a lot of patients, you fix their retinal detachment and yeah, you saved my vision, but I'm so happy I'm rid of all those floaters.
That's right.
Yeah.
That's a great point. And what do we have? 15% versus 5. So that's pretty good. It was 5. And then I think we're going to do our final poll question. Can't do all the good stuff without talking about the complications. So what are the things we worry about? And obviously retinal detachment is in a non-retinal detachment case. And cataract progression is in a patient who has a lens. There we go. Audience is pretty much on it. So let's just look at the numbers real quick. Can I do this? Hello. There we go. So yeah, I think the number is less, but if you look in the literature, they're reporting about 1 in 3,500 cases of severe infection, endophthalmitis, about 1 in 5,000 of choroidal hemorrhage. Approximately 1% are supposed to detach. I think this is a little high, but again, I'm using the statistics in the literature. The one thing I tell patients who are phakic or undergoing vitrectomy is what we talked about before. Do we want the cataract out first? If someone wants floater surgery, for example, I always say get the cataract out. If they have like no nuclear sclerosis whatsoever, they're 50 years old, I try to discourage them because you're going to give them a cataract very quickly. And then on top of that, what we talked about before, if you do it in reverse, you take, let's say, floaters out, and then they have cataract surgery. After vitrectomy, they have almost 100% rate of posterior capsular opacification. They go get a YAG laser, you blow all that material into the vitreous, and they have floaters again. So I don't know if anyone has any different views on that, but cataract progression, I'll say one more side point before I let the panel take over, but I had one patient, I think he was 2,200, and he came back to me, I think 2025 after retinal detachment repair. And a few months later, he comes in screaming at me because he's 2040, 2050. You never told me that I would get a cataract after this surgery and you're lying to me. And he's just carrying on. But literally from that day, I make sure every single patient I tell them who's phakic that you're going to get a cataract after vitrectomy surgery. And at least then they're expecting it. Panel?
Yeah, I agree. That's inevitability if they're phakic, and that's always a consideration for those that have floaters, younger patients that, you make a decision for surgery, you're buying this too. The younger patients that start with a clear lens aren't necessarily going to get a cataract in 6 months. It could be a few years, but they will. It's just going to progress faster than otherwise. And that's part of the deal. That's not a complication. That's a side effect.
I agree.
Just accept it.
Yeah,
Yeah,
I always
like
just said,
Go ahead.
I always just said that's part 2,
Mhm.
the cataract surgery.
Yeah, right. So, everyone, of course I tell everyone will get a cataract, but pretty much most people just accept it very well, because it's and low risk and successful surgery. So most people deal with it pretty well.
I agree. And that's all I have.
Well, that was fantastic, Adam. Thank you so much. That took a lot of work, but it was right exactly what we were looking for. I see that Zach has sent a link for those of you who are looking to tag out. We are over an hour, and you can get your COPE credit. Zach, I don't know if you have any other announcements you want to make about further meetings.
Yeah, so we got for those who are looking for credit, so we have our in the text function is the link for our OD colleagues who are looking for COPE credit. If you just go fill out a survey, provide your information. If you have questions about it, Kendall Johnson is our contact person for all things credit-wise. For our MD participants and DO participants, the link on your left is what you want for your CME credit. If you just scan that QRS code, it will automatically register your CME credit for you, or you can text that code at the top of the screen to that number. We have, and if you have any questions about that, you're welcome to email me. We do have one more meeting this year, so the last one, so we'll end with the best, which is another glaucoma section. So that will be, the topic will be managing the advanced glaucoma patient. So essentially, what do we do once the field is horrible, the OCT is horrible? What do we do with those patients, which sadly there are more of those running around than we would like. We'll
That's
have
easy.
another,
We send them to you.
expert panel.
Yeah.
See Dr. Best. Do not pass go. Go straight to his office.
I suggest we have a horror interdisciplinary meeting with retina, silicone oil, eyes, and glaucoma, but that's for the future. Zach, go ahead.
I will say, sorry, hopefully someone was saying that the QRS code is cut off. Is the QRS code visible for you all, or is it problematic?
Now it's
That's
visible.
better.
You able to, let's see, I'll make it full screen and see if that makes it. Does that make a difference in terms of being able to see the full QRS code?
Yeah, I see it.
Okay, all right, perfect. I think that sounds great, Peter. I think I had a patient I did surgery on this week, and he said glaucoma seems tough, and he did bring me a little bottle of alcohol to kind of help pass the time. So at least some patients do understand that they have tough eyes and do not make it easy on us.
Well, you know, the interdisciplinary nature of surgery is often influences what we do in the sequence in which we do things. But it does seem that glaucoma is a common specter in a silicone-filled eye. You have to be super careful. That can ruin the party if you've got a great repair, but the pressure spikes. That could be a very serious situation. Anyway,
I will say
how do you go ahead.
I will say on the multidisciplinary, I have never had a cataract consultation that has had a vitrectomy that has ever been upset that they were there for their cataract surgery. And almost every single one says, they told me that I was going to get this cataract, that I was going to come see you to get this cataract surgery done. So I think patients very clearly receive that message from you all. It's never been an issue from my standpoint.
Well, we usually just kind of sit around and chat. So long as we're having a conversation, we can continue the conversation here, but feel free to stay on board with us or sign off as you will. It looks like we still have 77 people on board, so we can talk about some interesting things if there's other thoughts there.
So I would have a question about, we talked a little bit about the, you guys mentioned the cataract coming out before the ERM is peeled. What counseling do you think is appropriate for a cataract surgeon to give a patient with an ERM before that discussion? Do they still need a consultation with you before the surgery? Do they just need to be told, hey, you may have to see a retina doc afterwards? What's kind of the appropriate way to set the table for those patients? Because with OCTs, I think we find a lot more of these patients than we did previously.
I think
I would get a retina opinion first, because then they're going to understand the process and they'll hear it from somebody else. So they'll have two people telling them the same thing. They're much more likely to remember it. And what we would usually advise, if there's both, get the cataract out first. If you're happy with your vision, then you're done. If you're not, you come back, see me, and we'll talk about removing the membrane. I think cataract surgery, you can answer this, Zach, but I presume is easier in a non-vitrectomized eye. So you'd much rather take the cataract out before we do a vitrectomy rather than the other way around.
Mhm. Yeah.
also
no,
the, go on,
agreed.
I'm sorry.
Go ahead.
Oh, the rate of CME is higher with an epiretinal membrane too. And it's nice to have the retina surgeon already on board, ready to deal with that if the patient gets postoperative CME. So they get their cataract out, and let's say the membrane's the same and their vision actually gets a little worse, you can send them right over. They're already plugged into the system, and then they either get treatment for their CME, or if it's due to the epiretinal membrane, that peel can be scheduled acutely.
What about oh, go ahead, Zach.
I'd say the second question would be, what about lamellar holes? So we talked about full thickness macular holes. What about lamellar holes? And is the question the same for the pre-op cataract patient? Because same thing, we find a lot of those incidentally in patients without metamorphopsia, no complaints, but then there's all of a sudden a lamellar hole on their scan.
Again, it's not bad to have the retina person look at it, because they can hear it from the retina person. Generally, what we're going to tell them is it's probably not going to be an issue for you. Go ahead and get the cataract out, and then see me maybe a couple months afterwards for a final look. And if they're happy, I don't need to see them again. But I think they'll remember then that there's something going on there. We can show them a picture, and it's in terms of patient education, I think it's a little better to avoid, hey, I didn't know that was there and the cataract surgery caused it, blah, blah, blah. Even though it didn't, but, patients get that in their head, that something that was there was caused by the cataract surgery. And this is a way to avoid that.
Yeah, it's just managing expectations. And as you said, it's a human nature to, what do they say, post hoc ergo propter hoc, after something, therefore because of something, we always would associate, the previous event for causing our current situation. But so that's advisable. On the other hand, I do think this goes to us all sharing technology. An ophthalmologist, general ophthalmologist will have an OCT and can probably properly identify and counsel patients prior to surgery without a retinal consult. Judgment call there, I'd say. What do you think about combo surgeries, doing a tag team, 2 doctors, cataract surgery followed by a peel? I have to admit, although there's a convenience factor that you can score points by accommodating a patient, I feel like that it creates unnecessary risk. Why the cataract surgery and the membrane peel surgeries are simple enough procedures to do independent of each other, but when you try and combine them, I mean, if you have a little corneal edema after the phaco, you're making that peel, the membrane peel, unnecessarily difficult. So I generally don't favor combining procedures, but it's debatable. What do you guys think?
I agree. And I also allude to what I discussed before. I like to create a posterior capsulotomy at the time of vitrectomy. So it's nice to have that lens kind of socked in. So you do the cataract surgery and then let it set for 2, 4, 6 weeks, and then go and do the vitrectomy. And at the time of vitrectomy, I always take the posterior capsule. That way they never need a capsulotomy. They never have to worry about the associated floaters. God forbid there's a little tiny bit of retained cortex or anything like that. We can address that at the same time. and it's a lot cleaner surgery. So I agree with you for many reasons.
There's also a logistic issue that retina surgeons and cataract surgeons more often than not operate at different facilities. And cataract surgeon may have their own surgery center and they're not set up to do retina. If you do it at a place where we do retina, say at the hospital, then everybody's out of their element. I think it's best that each surgeon be operating in their home court where they are used to the staff, the equipment, and they're going to get the best outcome that way, rather than compromising and going to a facility that you don't operate at frequently and you don't know the equipment, et cetera. It sounds easy. Yeah, just get together and do it. But the logistics of coordinating schedules and everything is a lot harder than it sounds.
I would agree with that from a cataract surgery standpoint. Just the logistics side is extremely difficult. Dr. Autumn and I operate on the same day lots of times. And even then, if there's a chance we may have a combination case, even then it is difficult to get on the same schedule in the same time. So I agree. Logistically, you should probably have the person do their best surgery where they're most comfortable. And that may require more than one trip to the OR for the patient.
These type of procedures are common outside the US, where retina surgeons routinely do cataracts. You see that in Europe and Asia and down under. So it's a lot more common. Retina surgeons in the US do not do cataract surgery, so it's not something we would do. But in Europe, for example, retina surgeons do cataracts routinely, and it's quite common there that they do combined cases. They do the cataract and the peel. It's the same surgeon, same sitting, same everything.
So Brian, I was talking to a colleague of mine down in Texas, and the retina group there is the group that actually does all the glaucoma tubes, just as an extension from previously tackling all the neovascular glaucoma. And I thought, tell me more about this, how I can punt some tubes onto my fine retina colleagues out here in town. They would probably be very happy to help me out, I'm sure.
Yeah, I think Peter wants to do those because he does plaques, and those are very similar to, valves and tubes. So send them to Peter.
I have thought that with our retinal detachment repairs or our patients that have tampons, it would be nice to have a temporary tube that would last about 2 weeks or so. So if you had an inadvertent spike, your pressure would go down. But I don't know of any such device. But it would be nice if we had one.
Just do a trabeculectomy. Back in the day, that's about how long they lasted, like when I was a resident.
Jeez.
There you go. Nice orphan trap. It'll be great.
Yeah.
Well, I did have the chance to scrub with Zach the other day and watch him at work. And I do admit I'm too far out from residency to really appreciate the skills that our colleagues have in other disciplines. And, I hope that this type of format we're providing here encourages us to share our notes and our experiences with our other colleagues. And, I know you guys are retina here, but I'd encourage you guys, if you can, if you have time, to come in on Zach's glaucoma one the next time. It's an eye opener to see the modern techniques in the different disciplines.
I will reverse that plug for pretty much everybody who's watching these videos that is not a retina surgeon. How difficult what Dr. Martidis showed us was incredible. And if anybody who is a resident and has been in an eye and has tried to hold a light pipe and move those instruments around, it looks like such a massive cavernous space that's being operated on, but the subtlety of those movements is incredible. Once you got to think about how big an optic nerve is and where those instruments are, I think everyone kind of appreciates that in some regard, but really when you look at those videos, I mean, you guys, all of you make it look so easy with your technique and your skills, but in reality, that stuff is, it is no joke what you guys are doing inside an eye. It is just really impressive. So I think that's the other thing, is we just always have to keep in mind what you guys are showing and what now is routine for you all, the macular hole peels, as you mentioned, Dr. Hovland, you're saying back in the past when vitrectomies for those MAC holes weren't a thing, here's what's your guys' bread and butter now. We should not lose the amazement at what medicine has brought us to and what can be achieved, and what you guys are able to do is just really impressive. And so I think that's the other thing, is the routine we should never lose the kind of the magic of what is now routine for you all to do.
Oh, yeah. I think some of the simplest inventions have made the biggest difference. I would argue the valved trocar, at cannula placement, the valve alone has just absolutely changed the surgery. Think of those 20 gauge ports we used to try and manage, and fumbling with the plug to seal them. And now with that self-sealing system, the exquisite control we have. I mean, the retina doesn't jump into the wound, so it's really come a long way. And I agree with you, Zach. And we always think today's the best it'll ever be. The future, I'm sure we'll have some other great things.
Now, this is going to be a little bit of a other question. You guys had mentioned using an ILM flap, and we didn't really clarify what that was very much. I got to see Moo and I actually did do a combo case the other day where I did see him do that, but I'd never heard of such a thing. So for those that are still hanging around, can someone explain what an ILM flap is and what you're actually trying to achieve with it in closing a macular hole?
Well, it's basically leaving a little bit of ILM attached to the edge of the hole, and then tucking it over the hole, or better yet, gently placing it within the hole. It provides a scaffold for the tissue to grow together and the hole to close. It's kind of like a skin graft, if you will. A flap is easier because one edge is attached to the edge of the hole and it doesn't fly around. The free floating piece of ILM, like you have a case that the hole doesn't close and you go back, you have to get a piece of ILM from further out and put it in the hole. And this is very delicate tissue. It's 10 microns thick, and it's flows around the eye. If you let go of it, you're chasing it. It's a lot easier to have a piece of ILM attached because it's not going to go anywhere. And basically just tuck it in. It doesn't have to fit exactly, but it provides a scaffold for glial cells to grow across the hole and close the gap. So that's how I view it. And that's the simplest. There's more sophisticated techniques out there with amniotic membrane grafts, or even autologous retina, where you go out in the retina mid-periphery and you cut a piece of retina and put that in the hole. These are more complicated, and I find an ILM patch or flap works pretty well at closing the hole.
Thinking of the future, we expect we may have OCT into the operating microscopes. I look forward to that. There are times, in a MAC hole case just last week, I peeled the hyaloid. There was a very tight bursa over the macula, and it came up, and I stained with blue, and I'm pretty certain the ILM came up with the bursa, but it took me a while to convince myself of that. And thankfully the hole closed. So I believe that's what happened, but it would have been great to have a OCT to examine the situation. Do you guys think we will end up using those down the road?
I definitely think so. I was actually, all the video that I presented was from formerly True Vision, which was bought by Alcon and became the Ingenuity. And they're actually working on that. So all those cases were not done through a microscope. They were done with 3D glasses looking at a three-dimensional screen, and the newer version has all the parameters on the screen. These are more raw videos from the original unit that we had acquired, but the next iteration is going to look at intraoperative OCT. So absolutely, I think that's sooner than later.
The Ingenuity system, we demoed that, and I thought it was spectacular. it was allowing you to visualize the eye in a way that was fascinating. You had improved, it seemed to me, stereopsis. I think there's so many adjustments you could make to that system, including selecting what spectrum, what wavelength you want to use to illuminate the retina. So it'll be very exciting, I think, in the future to see these things hopefully become affordable for us to get into our ORs.
Yeah, I mean, they've talked about some of the things that are on the horizon with the Ingenuity. They're working on a robot arm. You basically talk to the unit, if you will, and say, right eye. It literally, the robot comes, does facial recognition, knows where the right eye is, focuses, and then you get different degrees of freedom. So instead of just a flat view, it can actually rotate the head of the camera so you can see more peripherally or whatnot. I mean, it sounds like science fiction, but it's science at this point, and it's going to be reality within the next few years, which is pretty amazing.
Yeah.
I think the standard joke, excuse me, about robots is at this point you would take a 1 hour procedure and make it a 3 hour procedure with the robot right now, but
Definitely.
we'll see how it comes in. All right, anything else? This has been a lot of fun.
Yeah, this has been great.
Yeah, fantastic. Thank you. Thank you, guys. Thank you, Adam. And
Thank
Zach.
Yeah,
you.
great presentation, Adam.
yeah.
Yeah, excellent presentation. That was superb.
Thank you.
Yeah, it was
All right.
nice to meet you, Adam. Thanks again for doing it. It's great to have
great.
you in the neighborhood here.
No,
So
I enjoyed
I
it.
guess the complex PVR cases are going down to the Springs now as well.
Oh, yeah.
Right.
Just like it will, right?
Yeah, right.
But, I appreciate the opportunity.
All
It
right.
was a lot of fun.
Thanks,
All
everybody.
right.
Thanks, guys.
All
I'm
right.
signing off.
All right.
Yeah.
All right, well, thanks again to everybody for joining. Again, if you have questions, concerns, don't hesitate to reach out to me or Peter or Kendall Johnson. If you have problems getting credit, again, thanks to Adam for that great presentation. Thanks to Dr. Liu, Dr. Hovland, and Dr. Jundup for joining us as well. And again, we'll be back in the first week of December for our glaucoma portion and final section for the year. Thank you very much.
Thanks.
Thank you. Bye.